Bom dia. Todo mundo já leu a dica 6? Siglas e abreviaturas simplificam o trabalho de quem realiza os registros, mas, se mal usadas, complicam o atendimento por quem os consulta. Fique atento. Bom, o nosso Grand Round de hoje é um Grand Round que a gente montou às pressas, né? Tivemos que criar esse espaço na agenda em função de um colega, de um médico de renome internacional, que é o professor Mike, da Universidade de Boston, e que é um neurorradiologista, e a gente montou esse Grand Round dividido em duas partes, e eu vou passar a apresentação do Grand Round para o professor Leonardo, porque foi ele que trouxe esse colega de Boston para nos brindar com essa apresentação.
Então, bom dia a todos.
Só tem um anúncio aqui antes, para aí, que nós estamos com uma conexão com a Álvaro Alvim ao vivo. Quer falar, Gerson? Pode falar.
Nós estamos transmitindo ao vivo lá para o pessoal da Álvaro Alvim. Nós temos o professor Moriguchi lá e os acadêmicos e residentes. E isso é a segunda vez que acontece. Então, o Grand Round agora para Álvaro Alvim e provavelmente depois para o mundo inteiro, né?
A gente vai passar para o Boston, né? Então, bom dia a todos. É um prazer enorme poder participar desse grande round. Eu queria agradecer o Naz e a Nadine pela oportunidade, né? Na verdade, a gente não estava preparando esse evento para essa quarta-feira, mas em virtude da presença do Michael aqui, a gente resolveu aproveitá-lo nesse momento, né? E a ideia inicial era dividir essa apresentação em duas partes. Eu iria falar inicialmente sobre imagens, doenças não vasculares na emergência, e o Michael ia falar em doenças vasculares, né? E a gente acabou, nas últimas 24 horas, mudando um pouco em virtude de algumas razões. Primeiro, porque conversando com ele, assim, ficou claro que seria um momento único de aproveitá-lo muito mais do que só 15 ou 20 minutos, de repente fazer uma aula de 40 minutos e deixar o espaço muito mais para ele do que para a radiologia aqui do hospital. Essa foi a primeira razão. A segunda razão é que ele tem uma experiência muito grande com coisas do tipo custo-efetividade, relação dos serviços de radiologia com os meios, com as fontes pagadoras, com o serviço público americano, Obamacare. Então, também foi uma oportunidade única de poder aprender um pouco mais com ele e com a experiência que ele tem em Boston, no Mass General, nesse assunto. Então, o que eu vou fazer é uma introdução muito rápida sobre o assunto, né, imagem em emergência. Muitos desses dados aqui são dados que foram criados e avaliados em Boston. E esse é um estudo interessante que ele mostra basicamente um dado que para mim ele é até surpreendente, né? É um estudo canadense que tentou avaliar a acurácia do médico, seja ele um médico residente, um médico emergencista, uma formação geral, ou um médico mais especializado em emergência, e a acurácia desse exame para doenças neurológicas. O resultado final é que 60% dos pacientes que chegam na emergência e saem da emergência com diagnóstico neurológico se confirma depois de um tempo, e 40%, então, por outro lado, não se confirma. Então, aqui a gente já começa a entender por que muitos pacientes que chegam na emergência, existe uma pressão para que se tenha exame de imagem, porque se a gente parte do pressuposto que 40% dos indivíduos que chegam na emergência saem com diagnóstico, esse diagnóstico não se confirma no exame no decorrer das próximas semanas. Isso se adiciona a um dado que também é impressionante, assim, dado americano, a gente, não sei se é muito diferente aqui no Brasil, se não for vai aumentar, né? 83% das pessoas nos Estados Unidos, em Boston, afirmam que usam medicina defensiva como forma de se proteger de processos médicos ou de pressão dos pacientes. E uma das principais razões para usar a medicina defensiva é solicitar exames de imagem, né? Então, a gente começa a ter uma ideia assim de realmente, bom, se eu tenho pacientes que estão chegando muito na emergência, eles, ao sair o diagnóstico, não se confirma muitas vezes, eu preciso fazer mais exames para conseguir confirmar isso, vou usar mais exames de imagem. E aí eu tenho uma lista enorme, no caso de doenças neurológicas, para fazer uso. Então, CT simples, angiotomografia, perfusão por CT, ressonância magnética, perfusão por ressonância magnética, angiorressonância, ou, o que é mais comum, uma combinação dessas ferramentas, né? Então, quem trabalha com radiologia sabe que é muito comum, o paciente chega na emergência e é solicitado um exame de imagem, é frequente ser mais um exame, tomo e angiotomo, ressonância e perfusão, ressonância e anjo, e assim por diante. E o que se imaginava é que um método poderia substituir o outro, e se a gente for para a literatura, a gente vê que isso não tem acontecido, pelo menos nos Estados Unidos, né? Então, esse é um gráfico que mostra o uso de CT em vários estados, não tem crescido, só que a ressonância tem aumentado. Então, se adicionou ressonância, mas não diminuiu o número de tomografias. Então, está se adicionando mais exames na avaliação inicial desses pacientes. E o custo, obviamente, está aumentando. Então, se a gente comparar o custo hospitalar, né, na última década, que é a década de 90, isso está continuando, e provavelmente tenha sido a razão de toda essa discussão sobre o Obamacare e controle de custos com imagem, com hospital, o custo hospitalar ele acompanha, o custo da imagem acompanha o crescimento do custo hospitalar, né? Então, como fazer para tentar inverter essa lógica, ou aprender um pouco mais com isso, né? E a ideia foi exatamente essa. A gente circulou pelo hospital ontem e teve a oportunidade de discutir alguns casos na emergência. E nós separamos um caso de ontem, que foi discutido, e a ideia é realmente tentar aprender com ele o que ele tem feito em Boston para entender um pouco melhor essa estratégia, como é que ele faz para usar CT, se ele usa CT e anjo-CT, se ele usa perfusão sempre, quando é que ele usa, quando é que ele vai para a ressonância, e qual é a razão disso, né? O que se espera desse tipo de exame. Então, eu vou mostrar o caso é uma paciente de 76 anos, com história de AVC, AIT, tinha um evento, uma sequela motora no primeiro dedo da mão esquerda, chegou na emergência com um quadro de paresia esquerda, desvio comissura labial, um NIH de 12 e um delta-T de menor que 4 horas. Então, evento vascular, aliás, um ictus agudo em janela terapêutica, com uma história de um AVC prévio, e o exame que foi solicitado foi uma tomografia de crânio, que é essa aqui, e agora eu vou passar a palavra para o Michael, ele vai discutir a tomografia, o que ele achou desse exame, e depois ele vai tentar mostrar para todos nós o que ele espera tirar mais desse exame e dos próximos exames de imagem que vão ser, poderiam ser utilizados nesse caso, tá? Então, até para introduzir o Michael é professor de radiologia da Harvard University, médico neurorradiologista do Mass General e é o responsável pela emergência de neurorradiologia do Mass General também. Então, Michael, please.
Thank you very much. Thank you all for inviting me. I have no idea what Leonardo just said, but I did see this case yesterday in the emergency room, so I know a little bit about this case. And what I'm going to do is, there's so many different levels here. So if this seems a little too hard or too easy, don't worry. At some point, there'll be something for everyone. But I want to speak here in the context of what are some of the findings here. And do I have a pointer?
In the middle.
In the middle, great. So in this case, we saw this woman come in with left-sided symptoms, which means we're looking for a right lesion. And this is an unenhanced CT scan. There's no contrast dye in the vessels. So you can see here at the top of the internal cerebral artery, there's a dense vessel. And you don't need contrast in the setting of acute hemiparesis and other symptoms contralateral to that to know that this is a top of the ICA embolus. And the question becomes, for making treatment decisions, do we give this woman IV TPA? Do we give this woman endovascular clot retrieval, which is a catheter approach, to put a catheter into the femoral artery? So what is the management of a case like this? And I could tell you that her images look not as bad as you might think, given how bad her clinical exam was. There is what looks like a hypodensity, a low density from a progressing stroke, an early progressing stroke, so this is already established. And by the end of the next half hour, I think you'll all understand what is the minimum necessary information that we need to answer these questions of, do we give IV thrombolysis, do we give interventional therapy? You know, you could talk for a whole week about different emergency room approaches, but I wanted to make sure that there are some basics that we all share. So one of the basics, now, oh, we have to put my talk up. But so so one of the basics, I think, is just looking at the head CT. And I think that there are good ways and not so good ways to look at the head CT. And so I think the first thing that's very important to know is the brightness and the contrast. You probably, most of you too young to remember black and white television. But when you set the brightness and the contrast, it decides what you're seeing. And you'll see these numbers that are up in the corner of the CT screen. And that refers to the Hounsfield units, the brightness of the image. Here you could see a small rim of hemorrhage, that 80 Hounsfield units. Here, the hemorrhage is the same brightness as the bone. So I'm not going to teach you in 30 seconds how to read a head CT, but I think it's important to remember that you need to adjust the brightness for what you're trying to see in the image. And so here's an example of an MGH physician who's 65 years old. He was an orthopedic surgeon seeing a patient in his office, and he suddenly became hemiparetic, and in 15 minutes, we had him down in the emergency room and we got a head CT. And how many people think the stroke is on the left hemisphere? Raise your hand. And how many people think the stroke is in the right hemisphere? Raise your hand. And how many aren't sure? Okay. How many aren't listening? Okay. So there's something very, very simple you could do, and we did this with this case in the emergency department yesterday, and that's just change the brightness, change the windows and the levels. And what does this do for you? Well, when you have very early stroke, you have cytotoxic edema, you have vasogenic edema, you have swelling. And that swelling, the water in the brain is lower density. Water has a Hounsfield density of 0. And gray matter has a Hounsfield density of 35. And white matter has a Hounsfield density of 25. And the difference between gray matter and white matter is very small. But if you make the window width less, if there's very subtle edema in the gray matter now goes from 35 to 25 with that edema, but with the right display setting, it's much easier to tell. So now how many people think that it's on the left, the stroke? And how many people think it's on the right? Still not so sure, huh? Well, I think what you're seeing here is bright gray matter and dark white matter. And here it's just all dark. So the stroke is actually on this side. And when you got the follow-up scan here, this is what it looked like 2 days later. And all that area that was very, very subtle, a little bit of edema, that all went on to be a stroke. So I think just lesson number one is when you're reading a head CT for a stroke, one of the things you have to remember to do is try to see the gray matter and the white matter and set your display so you could see the difference. That's lesson number one in how to read a head CT for a stroke. Lesson number two, and this was actually the first paper I ever wrote. And we showed that we went from about 55% to over 70% accuracy in picking up the stroke in the ED just by looking at that. And this may not seem like that big a deal, but the reason it was is that when I wrote this paper in 1999, we had just recently started using PACS a few years earlier. We had only printed film. And printed film uses silver halide. In fact, we had to fire one of our technologists because he was selling the old scans to melt down for silver. But it was very expensive, and you couldn't print all these different windows and levels and settings. But now you have it on a digital display, so it's easy to do, so you should do it. You should look at it. The other thing in the ED, not just for stroke, for everything, try to get your CT scans with coronal images. Do you do already coronal images? Because if you had a very subtle infarct, or let's say you had some blood layering along the Sylvian fissure, if it was just in the axial and there was a little blood in the sulcus, or this little bit of hemorrhage from trauma that's in the inferior frontal lobes, it's very hard to see that with the beam hardening in the axial. But on the coronal, it's very obvious that there's a big frontal contusion. So the other thing you should do is you should look at things in multiple planes, coronal, axial. This is just how to read a head CT 101. Very, very basic, but important. The other thing that most people don't realize is when I went to look at the scan in the ED yesterday, everybody had these big magnified images. And I will tell you, you see things differently when the images are big and magnified and when they're tiny, because your brain filters the graininess, the noise differently. So this is actually from a physics book. Brian Greene, who I went to high school with, took 2 different images of different people and just put them through a filter, a low-pass filter and a high-pass filter, and superimposed them into one image. So what I'm going to show you is the same image. One is magnified and one is small, but it's the same image. So who is that a picture of? Marilyn Monroe, okay? Same exact image. Now we're going to magnify it. Now, who is it? It's Albert Einstein. What's the difference? The difference is the big picture with Albert Einstein has a lot of noise in the fine structure. So when you magnify it, you magnify the pixels that show Albert Einstein. When you make it small, it's just the opposite. You pick up the very high frequency information, and you lose the noise that's Einstein. So it actually matters how big you look at the image. And what we found, I don't know if you know enough American history to recognize who that is, but even if you did, if you haven't seen this before, it's very hard because it's such big pixels. And you magnify noise when you magnify an image. But now when you make it smaller, you could see it's the same image, just smaller, but then your brain could filter it. And you see it's Abraham Lincoln. And it's just like modern art. You look at the pointillist paintings, you look at this, it's just points of color, because you're too close to the painting. And when you move away from the painting, there's the same painting from far back. Now you can see the big picture. So I think when I first look at an image on a CT, I always try to look 4:1 or 6:1 for a stroke. I make the windows narrow, I make the images small, and that really lets your brain pick up some very subtle findings of edema that would be very hard to see otherwise. So this is just how to read an unenhanced head CT. Okay? And the other thing in the emergency room is that although I didn't understand what Leonardo was saying, I did follow the slides that he was showing, and he was showing how imaging costs are going up and people practice defensive medicine, but I think there's good reason in the ED. Now, in fact, the stroke protocols that I'm going to show you momentarily are to try to do the minimum imaging possible to make a treatment decision. And I will tell you right now, a lot of people use fancy perfusion imaging, and they have to do CTP or MRP, and that has usefulness, but you don't need the very advanced imaging to make the very basic decisions in stroke. And so I think the first thing I want to say is that when you're in the ED, the equation of risk versus benefit and cost versus benefit changes a little bit, because you have to remember certain things you do have to be defensive about. If you have a patient come in with chest pain, and the chest pain goes away instantly with some antacid, with some Mylanta, do you send that patient home from the ED and say they have esophageal reflux? Or do you get your EKG and your enzymes and your observation? No, you rule out the MI, even if you're 95% sure it's gastroesophageal reflux, because if you miss 5% of heart attack, it could kill someone. So the whole risk to cost and risk to benefit changes. And there's a very few diagnoses like that, but stroke is one of them. And only less than 5% of people come into the ED and get treated for stroke. And so you want to make sure before they leave the ED, even if they get better and they have a transient ischemic attack, a TIA, even if they improve, you still want to look at all their blood vessels. You want to know if they have a carotid stenosis. You want to know if they have an arch dissection. And then you probably want to make sure they're not in atrial fibrillation. So you want to do all that because TIA is like angina. You wouldn't send someone home with cardiac angina without doing the full evaluation. You shouldn't send someone home with a TIA without doing the full evaluation. And what is the full evaluation? Where's the stroke source? Is it from the neck, from an embolus, from the heart? You have to understand why they had the TIA, okay? And because I know there's a lot of people who are not radiologists in the audience, I could tell you that the number one thing that you could do to help the radiologist is to make sure that they know what's going on with the patient. Because you could have a hypodensity, a low density, like I showed you on that first case on a CT scan. If I told you it's a 35-year-old woman with sensory symptoms, it might be multiple sclerosis. If I tell you it's acute onset of hemiparesis, it's probably a stroke. If I tell you it's chronic onset of funny gait and memory changes, maybe it's a tumor and we need to get an MR. So very simple. We need to know the gender, the age, the specific symptoms. And it always helps in the emergency room to know if someone's immunocompromised. If someone comes in with back pain and they have AIDS, I'm going to want to do some contrast and think about discitis osteomyelitis for the back pain. So it changes your Bayesian, your pre-test probability. And it decides what the imaging is and how you interpret the imaging. And this is just an example. This is a T1 coronal hydrocephalus patient. But if you don't have the right history, you misinterpret it. You give the wrong interpretation. So you need to know the interpretation. And this is like the case we saw yesterday. When I see this very dense vessel, this little dot sign in a head CT, it could be anything. It could be some slow flow in the vessel. It could be artifact, calcium, volume averaging. But as soon as I saw the case yesterday in the ED and knew that on the left there was this, and I said, did this patient have a right-sided hemiparesis and aphasia? And the answer was yes. I don't need a CTA to tell me those are the M2 branches that now have acute clot in them, and that's what's causing the stroke. But to make that, I need to know the side, the laterality, the symptoms, or else this could be anything. You have to have the clinical correlation when you're interpreting the images, or it just doesn't work. And in fact, we showed that. Now, there are some things that are very easy. Diffusion imaging is not perfectly a yes-no, but pretty close. And if you have an acute area with dead brain, it's going to show restricted diffusion, bright signal on the DWI image. That's very, very accurate. But on a CT, one of our old fellows, Mark Mullins, who's now the chief of the residency program at Emory University in Atlanta, did a very nice project where he took all our CT requisitions from a whole year and he divided them into two piles. One pile where we had the history of rule out left-sided stroke with hemiparesis, something very specific, where we knew what we were looking for. And the other pile said, change in mental status, or dizzy, or something very general. And it was just like that other data. When we had the very specific history, we had close to the right diagnosis about 65% of the time. And when we didn't, it was actually less than 50%, which is worse than flipping a coin. So again, you really need to communicate, especially in the ED, where things are changing very quickly. Now, I showed all this yesterday. If I'm repeating it for people who heard this yesterday, I'm sorry. But I just very quickly want to make sure, before we get to the advanced stuff, that we're all on the same page. So stroke is a clinical syndrome. 15% are hemorrhagic, 85% are ischemic. Embolic is the type we treat. Embolic is by far the most common. Low flow border zone is unusual. It's from hypotension. You have to have a fixed stenosis. And anoxic is like drowning, carbon monoxide poisoning, suicide, strangulation. It's global ischemic change. It's rare. And again, to screen, we're trying to use whatever modality is the least expensive, like ultrasound to look at the carotids. If you're getting an MR of the brain anyway because you're looking for a seizure or a tumor or some other lesion, you could screen with an MRA just because once they're already on the scanner, it's actually cheaper to just finish the scan and get that extra sequence than get them off the scan and get a whole other test. But I will tell you that this is one of the big take-home messages. If you remember nothing else, one of the big messages is if you're in the ED and you want to know if there's something wrong with a blood vessel, a dissection, a stenosis, an occlusion, short of putting a catheter in the femoral artery in the groin and threading it up and injecting it, you want to do a CTA. That's your most accurate way in the acute setting to look at the blood vessels to know what's going on. And I do want to point out that one of the dangers in low-flow stroke, anoxic injury, is that it could look very symmetric. So with global anoxia, if you don't use the same trick from the CT scan, changing the brightness and the contrast, I made the brightness and the contrast to show a big difference here between gray matter and white matter in the diffusion. And this is global carbon monoxide poisoning, diffuse cytotoxic edema with gray matter infarction. But you could miss this if you don't see it's dark on the apparent diffusion images, restricted on the ADC. So same thing as with the head CT. You really want to make sure you're making the display setting so you're bringing out differences. And it's very hard when lesions are symmetric to make sure you're seeing the correct thing. So it's something to keep in mind when you're looking for that. And of course, you want to rule out stroke mimics, which are 10 times more common than stroke. Seizures, syncope, sepsis, migraine is a big one. Now, what about the embolic strokes? Those are the strokes we really want to treat. Those are the strokes that are going to cause loss of life or loss of employment or having to be bedridden or put in a nursing home. And those are really mainly the first two categories. Stroke from carotid artery stenosis makes emboli, and stroke from atrial fibrillation makes emboli, and that's in adults. Those are the most common causes of bad stroke. The next most common cause is end vessel, hypertensive lacunar strokes in the deep gray matter in the basal ganglia in the brain. And when you see a young person come in with a stroke, you're looking for two things. When I see someone 25 years old come in with a focal lateral stroke in the ED, I want to know if they have a dissection or a DVT, a deep vein thrombosis, with a venous embolus through a patent foramen ovale coming up through the heart. And those are the diagnoses at the top of the list. And proximal emboli are very common, again, from atrial fibrillation, from carotid stenosis. Those are the bad ones. Those are the ones you want to treat. So it maybe is only 35%, but it accounts for 80% of the poor outcomes. And lacunar infarct from hypertension is only 20% of all strokes, but it's about 90% of the good outcomes. And if the initial symptoms are mild or minor, they're probably going to do okay, but you still want to do all that imaging to prevent a bigger stroke or to prevent worsening. So the goal, once someone has come in, is really to prevent worsening. And the best prognostic indicator is just how big is the stroke at admission. That's another big take-home message. How much brain is dead at the time the patient comes in? And I will tell you right now, the only way to know that for sure of how much brain is dead when the patient comes in is to look for the diffusion image. The perfusion image does not tell you that. You can have an 80% reduction in cerebral blood flow, and if you've only had it for 15 minutes and you could give some TPA and you get reperfusion, most of that brain may be okay. So one of the big take-home messages, you cannot image infarct core. You cannot know for sure if you have dead brain just by looking at the perfusion image alone, because the perfusion image is a snapshot in time. Now, if you have low perfusion and it's already low density on the CT, that means it's vasogenic edema. And that is probably going to be a complete stroke at that point. So this is actually our algorithm, and this is my whole talk. And I'm going to spend some time showing this, and then in the next 15 minutes, I'm just going to jump to a few very important slides to make some points about what's important from this. So basically, what we do is everyone who comes in who may have a stroke gets an unenhanced CT. And if there's no blood and there's not a big stroke that is already complete and really hypodense and more than a third of the hemisphere, they can get TPA IV, and they're going to get TPA IV. Now, you don't want to slow down treatment. You always want to treat as quick as possible because everyone talks about time is brain. But that actually turns out to be a little more sophisticated than that. And that's a little bit of an oversimplification. But you still want to treat as fast as possible. And so at this point, you'll break open the TPA and you'll start mixing it. Now, TPA is a couple $1,000s a pop. So once you open the TPA, you've made a big cost commitment. So at this point, that is really all the information you need to make the TPA decision. No bleed, not a big stroke, all the other clinical features. Let's pop open the TPA. It takes 10 minutes to mix. During those 10 minutes, we'll get a CTA because you have to see the blood vessels. And if on the CTA there is a large vessel occlusion, there is a blockage in the circle of Willis, in the intracranial arteries, then we will get a diffusion scan to look at how big the stroke is. And if the stroke is small and if there's a large vessel occlusion, we'll do clot retrieval. We will do endovascular stroke treatment. We will activate the whole embolization team. And that pretty much is our algorithm. Now, if we can't get MR, we will do CTP. But remember, CTP is not DWI. The CTP helps in a lot of ways. It helps in differential diagnosis. It helps let us subtype the stroke. It gives us some sense of how much is at risk. But I will tell you this. If you have a vessel occlusion and a small infarct, you're going to have a penumbra. You're going to see a perfusion lesion. So the CT perfusion or the MR perfusion is not telling you anything you don't already know. It's not adding information. Vessel occlusion in the brain, small stroke means there's tissue at risk. Okay? And you really have to look at numbers needed to treat. So with the new ECAS-3 data, we'll treat out to 4.5 hours with IV TPA. And even though that's not on the FDA package insert, the FDA package insert says 3 hours. We use the ECAS-3 data. We go to 4.5 hours. And we say for a 1-point improvement on modified Rankin score, which is the 6-point outcome scale, we'd have to treat about 6 people. Under 3 hours, you'd only need to treat about 3 people. And in the first 90 minutes, every 3 people you treat with IV TPA, you prevent 1 death. So time still makes a difference. And this is our ED flowchart. According to the Get With the Guidelines certification for level 3 trauma centers to call themselves stroke centers in the United States, we have to have a door to CT time of less than 25 minutes. Our median time in the last 1.5 years has been 15 minutes. And I don't think we've gone, except for 1 or 2 cases, much over 20 minutes. And then it takes 10 minutes to mix the TPA, so there you go. But the only reason we were able to get everything done that quickly is that all these different colors are different physician groups and nursing groups and EMS people and administrators. These dark blue, that's radiology. These are all other ED acute RN. All these things are happening in parallel. And it took us 3 or 4 years to work out this flow chart and another 2 or 3 years to get it to work. So it really takes a lot of cooperation from every department, and it's very complicated. And it's like this thing that was in the New York Times when they were invading in Afghanistan, and General McChrystal said, once we understand this slide, we're going to win the war. So it's the same thing. You have to have all these people working together in parallel. And so I think these are the take-home messages, that perfusion can't replace DWI for core for treatment decisions. Mismatch may help in differential diagnosis. It may tell you you have a stroke, but mismatch is not necessary to make the treatment decision. It's just not necessary. And there are trials like the tenecteplase trial that used it, so it can help, but there might be easier ways to do it that the tenecteplase trial didn't look at. And so I still have about 10 minutes. I'm going to expand on some of these ideas just a little bit. And again, we use perfusion for differential diagnosis, subtype, prognosis, to know if a patient needs to be in the ICU for nifedipine or hypertensive treatment. If there's a very low CBF in the penumbra, we might want to keep the blood volume and the blood pressure up because there are treatments other than TPA. And basically, what I said earlier, level 1 evidence, widely recognized, diffusion is the gold standard, the operational gold standard for dead brain. If you really want the real gold standard, it's flumazenil PET. But you're not going to get a flumazenil PET scan in the ED on anybody with a quick turnaround. So diffusion is not perfect. There's always some caveats. But operationally, it's what we use. It can have some reversibility. And one of the most widely appreciated facts in study after study after study after study is that the size of the lesion, the amount of dead brain, is critical for prognosis. It's one of the most important features. And in patients who have less than 70 cc's, or let me put it the other way around. If patients have more than 70 cc's of dead brain at admission, 70 mLs, no one has good outcomes. How do I define good outcome? Modified Rankin score 0, 1, or 2. Independent functional. And 2 is even on the fence a little, is kind of fair. No one has good outcomes. How do you measure 70 cc's? That's about a third of the hemisphere, a third of the territory at risk. If you measure the lesion length times width times height divided by 2, that's a quick approximation from the scan. So you could get a very quick approximation of 70 mLs by doing length times width times height over 2. Now, we've talked a lot about exclusion criteria for stroke. You don't want to bring someone to clot retrieval, to thrombectomy, if they have more than a third of the brain, or if they have a bleed, already infarcted. But what about inclusion criteria? Who is most likely to benefit? We really don't have good imaging markers for who's likely to benefit from a treatment. So I'm just going to show you a couple of things that are kind of newer and that we've been looking at on the scans that help. So one of the things that we noticed on that very first case, I didn't point this out because we didn't have all the thin slices, but we did point out that you had that hyperdense vessel, that clot in the vessel on the unenhanced scan. It actually turns out, and this has been validated in a lot of different studies since Rydell did this, and Rydell's work, I know you guys are doing now with Raul Nogueira, a large interventional thrombectomy study, okay? All of the new studies for thrombectomy use this as part of the biomarkers that they're looking at on the unenhanced scan. And in the Penumbra device, in the Solitaire, and the Trevo devices, they've adopted this. And what this basically is, it's the length of the hyperdense middle cerebral artery. And you could see if the length is more than 8 millimeters, once it hits 10 millimeters, the probability of recanalization with IV TPA alone is nearly 0. So this is a futility marker for IV TPA, and it's basically saying that if you have any chance of treating this patient, this is the type of patient you're going to want to have thrombectomy. You're going to want to use a catheter treatment. The other big category in addition to more than 8 millimeters, this patient also had, which is a T lesion, a top of the carotid artery clot in the brain that is going into the middle cerebral artery and the anterior cerebral artery, a T lesion. That's another futility marker. In all the subgroup analysis of IMS3 and MR rescue, none of those patients did well with IVTPA alone. Those are the patients who needed thrombectomy. So those are the subgroups. So this tells you who's going to benefit from endovascular stroke treatment. If you are getting an MR and you're getting the susceptibility, we haven't even published this yet. We just finished it. Livia Moret from Sao Paulo, one of my research fellows, did a very nice project, and what she found was of the 8 parenchymal hematomas we had after the endovascular clot retrieval, 7 of them, in retrospect, had this sign. And what was this sign that predicted a big hematoma after endovascular stroke treatment? It was a very, very thick clot on the susceptibility weighted images. And if the clot thickness was more than 5 millimeters, I don't know if some of these were actual vessel ruptures. So I don't know if this is a marker for the friability of the vessel, the ischemia of the vessel wall. It could be a marker for just how long the procedure is taking, how many passes you have to make, how much intravascular pressure you're increasing by putting the catheter up. But 7 of the 8 big parenchymal bleeds all had this sign. So this is something that we're looking at more closely as a way to exclude or at least say high risk for endovascular treatment. So we got very interested in the insula. I probably don't have enough time to really go into this in detail, but all right, I'll show a little bit just because this is so interesting. So I don't know if you guys are familiar with the idea of the cardiunculus, but one of the complications of stroke that is very worrisome is ventricular arrhythmia, sudden cardiac death. And it's been known for a couple of years that patients with stroke in the right periinsular region are at higher risk for ventricular ectopy, troponin elevation, and cardiac arrhythmia and sudden cardiac death. And it turns out that there's some areas in the right insula that are actually have autonomic vagal nerve control for arrhythmia, and that's the cardiunculus. And we had a very interesting problem in our stroke meetings at Mass General where we didn't have enough speech therapists to do the swallow screen on every patient to see if they could take PO meds after mild and moderate strokes. And just for fun, we said, let's see if there's a region of the brain. And we got 2 very, very well-matched group of patients, like 250 patients in each group. And it turned out that both those groups had identical rate of brainstem stroke, identical rates in both these groups of superior laryngeal nerve dysfunction and swallowing difficulty. But the patients with right periinsular stroke had more hospital-acquired pneumonia. And what we think is going on is that in addition for the right insula having some autonomic control of the vagus nerve, superior laryngeal nerve swallowing, some increased risk, we also think, and there's been, this is total speculation, don't go telling anyone I said this, now I'm speculating. But it seems from a lot of animal experiments that the right insula region might have some neuroimmune modulation, control of the immune system by vagal nerve fibers going into the thymus, T-cell release, B-cell release, susceptibility to infection. So it actually turned out we kind of found the hospital-acquired pneumonia center for the brain, and that turned out to be the right periinsular region. So the insula had all these kind of interesting functions, and we've done other things with the insula. We've made all kinds of different motor, aphasia, speech, all kinds of different models we've built for predicting improved outcome. And the one thing every single one of those models always had in common was the insula. So we decided, let's take it the insula just as a marker for stroke outcome, just like that 70 mLs. Could it tell us something about that 70 mLs with the insula? And we first did a voxel-based analysis just looking for ischemic thresholds. And it turned out the insula was the highest ischemic vulnerability. In other words, with the rest of the brain could survive for, let's say, 30 minutes with an 80% reduction in blood flow. The insula could only survive 30 minutes with a 50% reduction in blood flow. The insula was more sensitive to ischemia in a lot of these different analyses. And the insula was one of the first early ischemic signs described in CT by von Kummer in ECAS-1. So we've known about the insula as an early ischemic sign for 20 years, the insula ribbon sign. Now there's a reason that it turned out that that was one of the first stroke signs was discovered on CT, and I think the reason is the insula goes first. And the insula is the biomarker for what's going to happen to the rest of the brain in the next 24 hours if you don't reperfuse. Because the insula is the confluence of all the different vascular supplies from the anterior division of the MCA and the inferior division of the MCA. And it's almost like the integral, the summation of how good are your collaterals, how big is your clot. All of the factors we discussed about 8 millimeters and T lesions, they all contribute to this early ischemic change in the insula. So the insula infarcts first. And we decided to see, does how much the insula infarcts predict how much the rest of the brain is going to infarct? And the answer turned out to be yes. And we just published this in Stroke in September, just 2 weeks ago. So this article's in there now. But just to show you an example, here's two almost identical patients. So here's a patient, 51, 5 hours post-stroke, admission NIH 13. Here's his stroke at admission on diffusion. Very tiny, just the putamen. Actually decent collaterals. He has an M1 partially occlusive thrombus going all the way to the MC bifurcation on CTA, to the M2. But he has 100% insula ribbon infarcted. How much did his infarct grow into the penumbra, into the MTT penumbra? It grew 60% into the penumbra. So this tiny little putamen stroke, and I'm not showing you the higher slices, became a much, much bigger stroke. Because he didn't recanalize, he didn't get treated, the stroke grew into the penumbra, but the insula infarcted first. Here's almost the same patient, 34, 5 hours, NIH 11. He has 0, same putamen infarct, same looking collaterals, distal M1, MCA bifurcation, decent collaterals, big infarct of the putamen, 0% insula ribbon. His infarct barely progressed at 48 hours, just teeny bit more. Teeny bit more. And we looked at the insula in quartiles, 25%, 50%, 75%, 100%, or 0 insula infarction at admission. And it turned out it was very dichotomous. Patients who had 0 or less than 25% insula infarcted at admission had very little penumbra loss, very little infarct growth. Patients with more than 25%, lots of penumbral growth, lots of infarct growth, lots of penumbral loss. And it was very discrete. It wasn't subtle. You have a little insula infarct at admission or a big insula infarct at admission, and it predicts, are you going to stay the same or are you going to get much worse? And it's a very high ROC curve, and it works clinically too. Although the clinical is a little more complicated because the clinical presentation is actually a measure of penumbra. Because the NIH score is actually the clinical penumbra. It's the amount of stunned brain. So with the clinical, it's almost inverse, that clinical, it tells you if you're going to stay the same or get worse, or if your penumbra, your insula is very small, you have the chance to get better. But if your insula is very large, your clinical is probably not going to get better. And it may even get worse. And Livia Moret did this other nice study where she looked at 66 patients who all had intra-arterial endovascular stroke treatment. And basically, their endovascular stroke treatment had yes, no recanalization. And we actually, in this one, we did it a little different. Instead of saying 25% of the whole insula, we just looked at the anterior insula, because that's more superior division. That's the one that was more important. And so we said, was the anterior portion of the insula more or less than half infarcted? So you could see, if you have more than 50% of the anterior insula, or more than 25% of the insula as a whole infarcted at admission, and you have an M1 occlusion, and you do not recanalize, your median infarct growth is 150 to 200 mLs. If you have more than 50% anterior insula infarct at admission, and you do recanalize early, you only had about 0 to 50 ml infarct growth. So this was modifiable. So in other words, who is the target for treatment here? The target for treatment is actually patients with 100% insula infarction at admission, or more than 25% insula infarction at admission, who are at very high risk for lesion growth, who are still doing well. And at that point, the quicker you treat them, the better. And all these recent clinical trials, I have slides on them. I'll summarize it for you very quickly. IVTPA is actually better than we think. But IVTPA doesn't work well for T lesions, and IVTPA doesn't work well for more than 8 millimeter lesions. And those are really the big take-home lessons from the synthesis trial, from IMS3 trial, from MR rescue trial. So if you had a patient like that with a small insula infarct who was at high risk for treatment, let's say they were just about 70 mLs or had that thick clot sign, and I was trying to decide, should I treat or not treat, because treatment with endovascular might be risky, I'd look at the insula. And if I look at the insula and say, you know what, the insula is very small, it's less than 25%, this guy has a lot of risk factors for doing catheter therapy, for endovascular therapy, and he's going to do well no matter what. There wasn't even a statistically significant difference in how big the infarct growth was with recanalization or no recanalization. Recanalization didn't help that much if you had small insula infarction at admission. So your risk to benefit ratio is different. It changes. So this is useful information. And it shows for the clinical too. It's just inversed a little because of the clinical penumbra effect. So I think at our last meeting, Howard Rowley at one of the big stroke meetings coined the term traits, treatment-relevant acute imaging targets for conceptualizing risk-benefit. So I've showed you some of those traits that you want to look for to do the minimum possible imaging. The important traits are admission, infarct volume, how big is the dead brain at admission, is there or is there not a vessel occlusion, how long is the hyperdense sign, is there a T lesion, is there a susceptibility clot that's very thick, and the insula stuff is all new, but right now, I'd like to get your guys' help. I'd like to try to validate the insula in a big cohort and know if it really works. But I think the insula is going to be something else we might want to look to for these traits as well. And I'm going to stop there and open for some discussion and questions. Okay.
Alguma pergunta da plateia? I have many radiologists here, neuroradiologists. I have a question. What's the impact of the clinical management of the acute phase of this acute stroke related to the blood pressure?
So, you know, I think that one of the potential values for the perfusion is it gives you a sense of the quantitative extent of the tissue at risk and the degree. And I think that most of our patients are treated empirically to try to keep their pressure at least above a baseline. It's important to not put people back on their antihypertensive meds because you don't want their pressure to drop. And in fact, I have examples of some cases where we've had patients in the ICU that have a small infarct and a big penumbra, and they're doing fine, and 48 hours later, they were sent from the intensive care unit to the floor, and the nurse writing the transfer orders put back the admission antihypertensive meds, and we got called for a stroke code on the floor, brought them down for diffusion, and the penumbra infarcted because it was a border zone type effect, the pressure dropped. So I think you don't really need the CTP to make that decision, but we do use it clinically on the selected patients. And that's...
Alguém? Mariângela? No doubt?
Queria perguntar como é que o paciente ficou esse da emergência, porque eu não sei se eu fiquei com muita dúvida ontem discutindo o caso, né? Era uma lesão um quadro isquêmico agudo, tinha uma área hipodensa que poderia ou não ter mais de um terço cerebral média. Então, eu não sei como é que ele ficou.
Eu acho que foi a Rosane que manejou essa paciente na emergência, não? Márcio.
This is the emergency physician who receives this patient.
So,
So I was the attending physician of this patient. I'm an emergency physician, and also I have the backup of Renan. He's a resident from neurology. And I have to say that I was very concerned about this patient when she arrived because her deficit was not very big. Actually, she had a plegia on her left hand, and she got much worse. If you see her today, compared to when we received her, and I was concerned because he did right, I think, but according to what you said, that she had a T lesion, so it was okay not to make the thrombolytics. But on the first time, I thought that, well, why she's not receiving this thrombolytics?
So yeah, she was, the other feature that I didn't really point out is that when we saw that case in the ED, we saw 2 cases that day. And one of them was very similar to the insula cases that I showed you with just a basal ganglia infarct, but 0 insula. And we looked at that, and I said, this patient's going to do well. And that patient did well. This patient, now they were a little sicker to begin with, but still they even got worse than that. And this one had 100% insula on the CT scan. So that's N equal 2. Now just get us 200 more cases like this and we'll write the paper on it. So,
thank you.
You conduct this patient to intravascular thrombolysis?
So this was a tough one. You know, I don't know what our interventional radiologists and neuroradiologists would have chosen for this patient. And the reason she's kind of tough is because she also had some old strokes. And it's really unclear with a 70 ml, we use that 70 ml cutoff, but if you also have old strokes there, do you count that or not count it? So she was a very tough case, but we tend to try to be more aggressive if someone is young and has a lot to lose, and we think they're going to lose it. So we might have tried, with a T lesion, we might have tried to open that. I think we might have. And what would have decided it, actually, is we would have gotten the MR with the susceptibility. And I think if that big fat thing was more than 5 millimeters, we probably would have said forget it. But if it wasn't, we would say let's have a try. And that might be what we do. But I don't think there was a right or wrong answer for that one. The other interesting point is that people with right-sided strokes tend to have not as bad a deficit. And the deficit that they do have, because the parietal lobe, you know, you do the thing with drawing the clock, and people have hemispatial neglect. So people with right parietal lobe strokes are pretty happy. They don't even know they have a deficit. So you take that into account too.
Professor Apio.
Well, as regards all you said, considering indications for MCA, large MCA compressive craniectomy,
Yep.
is there any change considering all you said?
No, and in fact, none of what I said about endovascular triage is standard of care. Different centers do it differently. This is work in progress. I know in the German groups, decompressive hemicraniectomy is a very low threshold, and they have very good data saying it's very helpful. I think a lot of it is just local culture. We tend to not do that except for these very bad ones. I would say in that particular patient, and you know, I don't know if he left. I have a very nice slide, and it's one slide I'd love to show, if there's a way to show it, because I think part of your answer is we really try to look at the collaterals on the CTA, and that gives us a good sense, without even doing the CTP, of kind of this malignant edema pattern, the type of thing that the diffuse investigators, Stanford, Greg Albers, would call a malignant perfusion pattern, but we see that just on collateral imaging. So my sense was, just looking at the pattern of the infarction on her, she was already, what, 4.5 hours out, 4 hours out. She still had she had 100% insula, and she had the basal ganglia, but she still had a lot of good brain. So my guess is that at that point, if we had gotten a CTA, the CTA collaterals would have been okay, peel collaterals. I think those people are not as much risk if you could reopen them. And what the slide I'd like to show is actually, let me get all the way to this, but I think CTA collaterals is very, very helpful. And if you shut the lights down, I think you'll all see it a little better. But I didn't realize I had so many slides. This is just going to take a little bit. I actually had a lot more. I wasn't sure what we were going to talk about yet. But what I want to do, and I still have a lot more that I'm going to skip through here, because I thought if people were interested, I would talk all about IMS3 and MR rescue and why those were bad studies, and maybe some of the interventional people want to discuss that later. But I'll say one thing about is that time is brain is actually very variable. So first of all, here's a T lesion that is 2.5 hours post-ictus, already has a huge infarct. Poor collaterals, huge infarct over the whole hemisphere. Here is a similar patient with a T lesion, 8 hours post-ictus, still just has the small basal ganglia infarct. Now, this is the thing where if there's zero insula, they'll probably stay okay because their collaterals are great. But if it's 100% insula in this with a T lesion, that I'd probably treat. I look at the CTA though. And the thing I wanted to show you, and I actually brought for you this slide, just showing that the time is brain, just like with STEMI, dwarf to balloon time, you have to treat stroke quickly, but the take-home message is, it doesn't really matter what the clock says. If the clock says 8 hours, but it's just a tiny stroke that looks like this, there may still be treatments you want to do. And if the clock says 2 hours, but it's a big thing like this that may have malignant edema and hemicraniectomy, you might not want to reopen that vessel because it's just going to make the vessels protected. It's just going to make the edema worse. And what if you can't get a CT, rather if you can't get diffusion, how do you make that assessment? Because what I just showed you is a diffusion scan. So the answer to your question is if you can't get a diffusion, and I'm sorry, I'm skipping through all this clinical trial, IAT stuff, flare, what if DWI is unavailable? If you can't get the diffusion, you get that same information I just showed you by looking at the collaterals. And this was a paper Raul Noguera and Albert Yu and I did. And basically, the only category that made a difference was 0 collaterals on the CTA. And if you had 0 collaterals, absolutely poor collaterals, malignant pattern of collaterals over most of the hemisphere, that was equally good, with maybe one exception, as seeing 70 mLs on the diffusion. That told you the same thing as diffusion. So to answer your question, I get a CTA. If I saw 0 collaterals, I'd start thinking about hemicraniectomy and not doing the other stuff. But if I see any other pattern of at least some collaterals, I wouldn't be as worried. Okay.
Professor Nazi, yeah, just one final quick question, actually. After those 3 trials, basic, Professor, IMS3 and synthesis and MRSQ, and which you've been telling us about, basically on your interventional team, on your routine of opening or not opening the vessel, what really changed, if any, changed? Because you have all those knowledge before, and the trials came with some info about how good IV is and maybe how bad it is, but we know that people who have big experience open vessels know that if you have this 8 millimeter bigger vessel, or I mean, you have to open. So actually, on your routine, what changed after those 3 trials?
So I think when you actually look at it, I'm not going to pull up the slides now because we're done, but the subgroup analyses, in addition to T lesions, in addition to the long hyperdense vessel, treatment time really made a big difference. And one of the things that we looked at is that we've tried to identify in the system where we were losing time. And yes, we're going to do the T lesions. We're going to do the long hyperdense vessels. We're going to really be more aggressive about those. I think we really believe, and we just had, you could check another article we just published in Stroke this week, 35% good outcome rate in M1 occlusions with IVTPA alone, admission NIH greater than 10. So we think IVTPA is great. And I think that what happened, we could spend the whole day talking about all the things that went wrong with that trial. I'll just comment on 2 of them. One is that the time took too long. And there was no true equipoise. There was a lot of bias. And the reason there was bias is that we could bill for the Mercy clot retrieval device. And I'm not saying this in a cynical way, that we were trying to get money, but there was no equipoise. So if you have a treatment that you really think works, what are you going to do? A 35-year-old comes in with an M1 occlusion, no family around. Are you going to start calling people and get consent and run around and delay her treatment by an hour? Or are you going to take the FDA-approved clot retrieval device that you get paid for and put it right into her in 15 minutes and suck out the clot? So what I'm saying is those trials took 8 or 10 years to do because they were terribly biased. Patients weren't treated fast enough, and the ones that were treated fast enough, who were the best candidates, didn't get in the trial. All the good patients who should have been in the trial just got treated. And because it took 8 years to enroll patients, because only the sickest patients got enrolled, on look at the data on MRSQ. We've been talking about 70 ml. Do you know what the median admission lesion volume was in MRSQ? Take a look at the table in the New England Journal. It's 60 ml. These people were almost at the point where we would have excluded them from treatment. And the treatment changed. So even had it been a positive result, who's still using Mercy? Everyone's using Solitaire, Penumbra, Trevo. So the technology has changed. You have to do a fast, good trial. Everyone gets enrolled. You have equipoise, and then it's good. So what did we learn from this? We streamlined our times. We got people triage faster. We showed that this algorithm is cost effective. We actually will get, not that we won't do the CTA, but if we're getting a transfer and we know they're coming from an outside hospital, we know they have an MCA syndrome, we'll get them direct to MR now, get the diffusion, and send them right to the cath lab. So we're speeding things up. That's probably the biggest thing.
Great. Thank you very much.
Thank you very much, Dr. Mike, for your nice talk, and we hope to see you again here in Porto Alegre soon. Thank you very much.